Morning, everyone. I'm going to thank Dr. Seabi for the introduction, even though I don't think I got much of it. I hope a lot of you guys did from your side. But essentially, I'm going to be talking about a group of disorders that are quite rare, but we tend to see from time to time in our division. And that is the motility disorders, particularly the achalasias. And what I would like to do today is just introduce you to some of the modalities we have in our department for the workup, particularly manometry, as well as some of the therapeutic modalities we can offer our patients here at CMJAH. I'll start by introducing a patient, Mr. UM, a 35-year-old gentleman who was known to the neurology department and was diagnosed with generalized Myasthenia gravis in early 2017. He was also found to have a thymoma, and because he wasn't fully responsive to his medical therapy, he was offered a thymectomy. I believe it was in late, I think, November 2017. Subsequently, his neurology improved. I believe his bulbous, he had predominant bulbous as well as his muscle strength improved significantly after this operation. However, he was referred to us a few months later because of progressive dysphagia, as well as regurgitation, and he was noted to have lost quite a significant amount of weight. On his physical examination, at the time he was underweight and he had oral candidiasis. However, most of that examination was unremarkable. As were his laboratory investigations, he had a normal complete blood count, his renal function, liver chemistries. He also had some endocrine bloods done and some screening for some chronic illness, all of which were actually negative. So at some point, an upper endoscopy was done. And quite importantly, what was noted was that there was a dilated esophagus. He also had some pooling at the lower pole and a tight gastroesophageal junction. However, once the endoscopist was able to traverse through, the rest of the scope was essentially normal. This is an image here of his Barium Swallow, which showed mildly dilated esophagus. And you can appreciate that there is a little bit of tapering going towards the gastroesophageal junction. So at this point, it was quite evident that you were possibly dealing with the motility disorder. So then we endeavored to get him a higher resolution manometry, and the findings of which I will tell you in the next couple of slides. So before we go into the meat of the talk today, I just wanted to refresh just on a few basics. We all know that the esophagus is a hollow tube that runs from the oropharynx down to the stomach. The main function really is to transport food and fluid from the buccal cavity down into the stomach. Its upper border is the upper esophageal sphincter. It's about 20 to 22 centimeters, and it ends at the lower esophageal sphincter. As with all the hollow viscous organs within the body, it's made up of a mucosa, submucosa, and in the case of the esophagus, we have two layers, the inner circular as well as the outer longitudinal layers. And in terms of the innervation of the esophagus, it's innervated by the autonomic nervous system through the vagus nerve, and the fibers of which in the myasthenic and myenteric, so the myenteric as well as the myasthenic plexuses, which are in the submucosa as well as the muscularis respectively. I just like to emphasize, just hone in a little bit on the lower esophageal sphincter, because this has become important. This is the lower 2 to 4 centimeters of the esophagus, and it's essentially just a thickening of the muscular wall of the esophagus, and then it is fortified by a sling of muscle coming from the diaphragm, the right crux of the diaphragm, as well as the phrenoesophageal ligament, the main function of which is to prevent reflux. Just a recap on swallowing. I won't go into too much detail, but just safe to say that there are 3 phases. The oral phase is the voluntary phase. This is where you chew your food, mastication, as well as mixture with your saliva and formation of the bolus. The swallowing proper starts in the oropharyngeal phase. And this is really when you have closure of your nasopharynx by a soft palate, closure of your respiratory tree by your epiglottis, and then shortening of the oropharynx, thus leading to the bolus being transmitted into the esophagus. And then important to us today is the esophageal phase. And this is really the main kind of physiological mechanism here is peristalsis. A reminder, there are two types of peristalsis, or two forms, if I can put it that way. Primary peristalsis, which is more prevalent here, is stimulated by the onset of swallowing. And these are the rhythmical movements that go down the course of the esophagus to transmit this bolus into the stomach. There is secondary peristalsis as well. Not so much important here, but more so in your small bowel. And this is really related to, if I can say it's a kind of reflex that's related to distension of the organ by food bolus or by gas, and then leading to constriction above and then relaxation below, and subsequent cranial to caudal movement of whether it's the bolus of food or chyle or whatever the case may be. When it comes to symptoms of esophageal dysfunction, and in particular, when it comes to symptoms of esophageal dysfunction, and in particular your motility disorders, the cardinal symptom really is dysphagia. And just to touch, or just to remind, that dysphagia itself could be a 20-minute talk on itself. There are quite many different causes, and it's important really to take a history to kind of firstly localize the dysphagia. Importantly, patients may complain about dysphagia that they localize to the throat, or upper dysphagia, and that is mainly oropharyngeal dysphagia. This can be related to buccal abnormalities, can be related to neurology, particularly bulbar issues. And then, of course, when they localize it a little bit lower down, to localize it to the chest or to the upper or epigastric area, this is more likely going to be esophageal dysphagia. It's also important to ask the patient when the onset of the dysphagia was, as well as is it a complete dysphagia or is it a progressive dysphagia? So for example, if you had an elderly patient and they would complain of dysphagia initially starting with solids and then progress to soft foods, then it progressed to liquids, you know, in a patient with risk factors, you might consider non-benign lesion versus a total dysphagia, so it's solids and liquids. In a young patient, maybe you're dealing with a foreign body, or somewhere in between, you'd be thinking about your motility disorders. The other symptoms that are very specific, or specific for your motility disorders, are chest pain, non-cardiac chest pain, as well as regurgitation. But there are also a lot of other symptoms that are associated with disorders or conditions of the esophagus. So after you've taken a history, it's then also important then to do a thorough clinical examination. But for the sake of time, I'm just going to go straight to some investigations that we can do to kind of hone in on a diagnosis. So I'd like to separate them into investigations that look at the structure or mechanical issues in the esophagus. These would be things like your upper endoscopy, Barium Swallow, which look at the lumen. But there's also, it's important to look outside the lumen in some cases. So a CT, cross-sectional imaging of the neck, for example, or indeed even endoscopic ultrasonography. This is essentially a tiny little ultrasound probe on a duodenoscope that can look from within the lumen of esophagus, or stomach, or even the small bowel, and look through the wall, into the wall, as well as into surrounding structures. But again, I will focus today mainly on assessing esophageal function and our motility disorders. And so the two kind of main modalities we have here is a time-bearing esophagram, which is a bit tedious. It's pretty much like a Barium Swallow. However, you time at various levels, 1 hour, 3 hours, and then you calculate the column of contrast within the esophagus, and then you can then say whether or not there is a rapid or there's slow transit throughout the esophagus. I'll be speaking a little bit more about manometry in the next couple of slides. So if we bring it back to our case, Mr. UM, I was unable to get his pictures of his endoscopy at the time, but these are some of the features one might find, although they may be subtle, but if someone looks for them, they might heighten the likelihood that we're dealing with a motility disorder. So if you look in panel A, I get the impression that it's slightly dilated esophageal lumen. And in panel B, you can see right at the lower pole, there's pooling of salivary secretions as well as some particulate matter. And I mean, this is important to note, these patients are typically starved for maybe 6, 8, even 12 hours. So you shouldn't really get anything pooling in the esophagus. So really, this should be an alarm sign for those of us who are endoscopists. Just a recap on the barium swallow. These are the typical barium swallow features that one might find in someone who has a motility disorder, in particular achalasia. The first two, you can see slightly dilated esophagus, and you can see tapering towards the lower edge, as well as what's been described as a rat tail or indeed a bird beak appearance. I'm not sure if there are any birders in the audience. I've been told that maybe, panel 2, if you put it upside down, could look like a heron or a hummingbird. I'm not too sure, but this is what's been described in the literature, and not quite pathognomonic, but gives a heightened suspicion of motility disorders. The third panel is a little bit different in that you can see this corkscrew appearance. And this is typical finding in patients who have not only this low esophageal sphincter issues, but also having spasm throughout the body of the esophagus. If we look then at manometry, which is what I'm going to focus on today, it has been around for many decades. In fact, I believe it's more than 100 years, initially as experimental studies. But certainly, I believe since the 1970s, it made its way into clinical practice. So conventional manometry initially was quite bulky. There were 5 or 6 transducers that were placed throughout the esophagus, and then they could pick up differences and changes in pressure. In the late 90s, as kind of technology progressed a little bit, the transducers got a lot smaller and got closer together. One could get a more higher resolution, and hence the name High Resolution Manometry, and almost a 3D kind of picture as a swallow, as the peristaltic wave rather progresses throughout the body of the esophagus. And that's what you can see in the middle panel. And then with further kind of innovation and computer programs, they could compute this data with various algorithms and such to give us what we see now, which is this like topographical picture where your cold colors, your blues, indicate low pressures, and your high or your hot colors rather, such as your red, indicate your high pressure systems. And so you could get a very nice view of the swallow as it progresses through the esophagus. So there are many systems that are around. I believe 2 main types, water perfusing as well as a solid state system. This is the system we use here in our department. As you can see, everything is nice on a trolley. You have your computer, maybe even a printer with your system on there, as well as your monitor. And we use the solid state transducer, which is this catheter here, and the transducers are within the inside of the catheter. This unfortunately isn't a single-use catheter, so there is a sleeve that we put over this catheter, and once it's plugged into machine, we can then intubate through the nose into through the nasogastric route into the stomach, and then be able to commence the study. So it's done as an outpatient, right down here in 554. There are many ways to do it. However, the accepted, kind of internationally accepted criteria really come from the Chicago Protocol. And so basically, it's a very specific standardized way of doing the study. The patient will have either be in the primary position, it may either be supine or indeed sitting. And then you will do multiple swallows, so maybe 10, maybe 15 of small little liquid meals. And then you can repeat them, or you can do the change then to a solid meal in the secondary position. And then if the diagnosis is equivocal, you can also use some provocative maneuvers, such as a rapid drink swallow or a multiple rapid swallows challenge. So once you've then done the study, it's pretty much like an ECG or a fluke. Once you've looked at your technical issues, you then come to the analysis phase. And so this is a normal swallow. And just to walk you through some of the important features here, the upper band, the upper band corresponds to the upper esophageal sphincter, and the lower band that's labeled EGJ there corresponds to the lower esophageal sphincter. The swallow begins with decreased pressurization at the upper esophageal sphincter, as you can see at the top left. In fact, even the lower esophageal sphincter also has a decreased pressure. And then the swallow then propagates throughout the body of the esophagus until it reaches the lower esophageal sphincter. There are some important parameters that we all look at. Probably the most important is the integrated relaxation pressure. And this is essentially the average resting lower esophageal sphincter tone. So the normal is stated here as 15. It does depend on which system you're using. It does depend on whether you're doing it supine or sitting. So it is almost always around about 15 to 18. But in any event, if it is elevated, it's telling you that there's a possibility or that there is a problem with the lower esophageal sphincter, or there's an increased tone at the lower esophageal sphincter. The other parameters we look at is the DCI, the distal contractile integral. This looks at the strength of the swallow or the strength of the peristaltic wave. So there is a range that's been stated there. If it is less than 450 millimeters of mercury per second per centimeter, this is known as a weak swallow. And then if it's less than 100, it's actually an absent swallow by definition. On the other hand, if it's greater than 8,000, this is a hypercontractile or a spastic swallow. So those are the two kind of main parameters we look at. The other parameter is this contractile deceleration point there, which is marked right in the center bottom of the screen or of the swallow. This is where the peristaltic wave starts to slow down. So as the swallow happens at the upper esophageal sphincter, the force of the swallow gets quicker and quicker, if I can put it that way, until it gets to a point, and then it slows down until it ends. That is the contractile deceleration point. And the DL, the distal latency, is the time between the onset of the swallow and this point. And this is important because with every normal swallow, you should have a refractory period. So you shouldn't be able to swallow directly after initiating a swallow. So if that happens, this is called a premature swallow. And basically it's telling us that there's a lack of deglutative inhibition. So this, believe it or not, is actually a simplified version of all your motility disorders. So on the right-hand side in the blue, these are the disorders of motility or peristalsis. And as I mentioned, based on that distal contractile integral, they'll either be absent or they'll be forceful or spastic. But today I'll be focusing on the disorders of the gastroesophageal outflow tract. And these are your achalasias as well as your OGJ outflow obstruction. And crudely speaking, they are typified by an elevation in that integrated relaxation pressure or an elevation in the tone of your lower esophageal sphincter. So it is believed that it is quite of a spectrum of motility, or rather the motility disorders lie along a spectrum. The esophageal gastric junction outflow obstruction is typified by this raised, as I mentioned before, elevated low esophageal sphincter tone, or IRP, but in the setting of normal contractility throughout the body of the esophagus. So this patient might present with chest pain, with dysphagia, or other esophageal symptoms. If it's not addressed at that point in time, it can progress along the spectrum to what manometrically is defined as type 2 achalasia. And in this instance now, you have, again, still have your elevated integrated relaxation pressure or tone of the lower esophageal sphincter, but now you don't have peristalsis. And in fact, what I believe is that the peristalsis is now replaced by what we call is pan-esophageal pressurization. So I think that it's the esophagus, the body of the esophagus is a way of compensating to overcome this obstruction. And so this is diagnostic of your type 2 achalasia. If you are able to overcome that, then the symptoms may come and go. You may be able to eat, and then patients who have lost weight may gain weight, or patients may actually gain weight in the first instance. And then as you move towards the end of the spectrum, or so-called like end stage, this is now where you still again have your elevated tone, but now you have no contraction at all. And then you even get dilatation and of the esophagus. Sometimes we call it a sigmoid esophagus. And this is kind of the end stage of the spectrum of these motility disorders. Type 3 achalasia seems to behave, in fact, it looks manometrically a little bit different, which I'll get through as well. So if we look at the manometry, just to kind of emphasize what I just said in the last slide, the first manometry, or the first picture, bottom left, shows a patient with outflow obstruction. You can see the lower esophageal sphincter is elevated, or the tone is elevated, as evidenced by this hot red color. So it's extremely elevated, your IRP. But you have normal swallows propagating throughout the body of the esophagus. Interestingly, you can see that the level has gone up a little bit with the swallows. It can be normal physiologically. So if you're not swallowing and you're breathing, this baseline can vary a little bit as you have variation going up and down of your diaphragm. But obviously in the setting of pathology, or in the swallow, this could indicate that there's shortening of the esophagus. Again, maybe a compensatory mechanism to try and overcome that obstruction. Again, we move along to the second picture there. This is a classical picture of type 2 achalasia. Again, our IRP, which is the band at the bottom, is elevated probably in the range of about 90 millimeters of mercury. There's no peristalsis, and you can see this column, this green and yellow column going throughout the whole esophagus. And this is what we call pan-esophageal pressurization. And this is a typical picture of type 2 achalasia. In our classical achalasia, or the type 1 achalasia, in the third, is again your elevated band, not quite as high as the other two, but as you can see, there's absolutely no peristalsis. And then type 3, if you look at the top right corner, and remember that corkscrew appearance of the barium swallow, that was indicating that potentially there might be spasm. You can see there right at the bottom, just above the lower esophageal sphincter, you can see this hot red, high pressurized system, and that would be consistent with type 3. So it's a distal or the spastic achalasia subtype. So back to our case with Mr. UM. Just to emphasize, the diagnosis of these motility disorders, whether it be achalasia or indeed your disorders of peristalsis, cannot be made just on one swallow. So there is a protocol, as I mentioned, that we go through our 10 swallows or whatever, and it has to then be persistent throughout all of them. So this is Mr. UM's manometric study. We can see he has 3, in fact, maybe more than that. The first swallow is kind of bordered with a blue-gray box. The second swallow in the middle is with the red box with all the markers in the middle. And then you can see right at the end, I think it may have been a provocatory challenge where there was a rapid swallows. And in fact, the changes here are quite typical of type 2 achalasia. Again, we saw elevated integrated relaxation pressure. That's probably in the I think it says about 35 or so millimeters of mercury. There's no peristalsis, and there's clear pan-esophageal pressurization to try and overcome that, that blockage. So, I mean, I did a little bit of reading just to see if there's a link between achalasia and myasthenia gravis. In terms of the achalasia itself, I have already kind of alluded to it. It's the impairment of relaxation of the sphincter with aperistalsis. And the pathogenesis is really due to destruction of the ganglion cells within the eyebrows plexus. Myasthenia gravis, on the other hand, is an autoimmune disease where you have destruction of your acetylcholine receptors in the neuromuscular junction. And then it can manifest as your fatigability. You can have ocular or bulbar, or in fact even respiratory issues. Importantly, you can also have dysphagia, and can be quite common in patients with myasthenia, but it's often multifactorial. And in fact, in our case, it could be part or a mixture of all of those. So if you have a thymoma, which happens in 15% of myasthenics, you could have pressure effects or compressive effects on the esophagus. The neurology, a lot of the neurological disorders where you have bulbar involvement, you could have an oropharyngeal type of dysphagia. However, not much has been described about dysmotility in the setting, and there are just a few case reports that I've come across. So how do you manage achalasia? There are pharmacological measures that you can use, both oral as well as Botox injection. But really the mainstay of the management is endoscopic or indeed surgical. I have written the esophageal stenting, which is experimental, as well as esophagectomy. However, that is almost end stage, if not a palliative procedure. So when we look at, quickly look at pharmacology, there are basically your calcium channel blockers, as well as your long-acting nitrates and your phosphodiesterase inhibitors have been described for assisting with the relaxation of that lower esophageal sphincter. As a modality, however, they're not really that effective. The improvement has been described. However, this is really short-lived. It can be, depending on the pharmacology, can be as short as 30 minutes to an hour or two. So really, most guideline documents don't recommend for the use of these agents. However, in practice, we do use them, particularly if you're waiting for a more definitive therapy. But you can prescribe these agents in these doses before meals. Of course, we must remember the side effects associated with these agents, as well as some potential drug-drug interactions. So the one modality that does have a little bit more evidence is Botox injection. And what we do here is that we pour about 2 mils of Botox, 100 units, and we inject them into 4 quadrants directly into the lower esophageal sphincter, into the muscular layer at the lower esophageal sphincter. The mechanism is by inhibiting acetylcholine or presynaptic acetylcholine release through cleavage of the SNAP protein. And the success has been a little bit better than your pharmacological agents. Again, not really long lasting, about 1 to 3 months. In some instances had been described to last up until 6 months. And of course, then the adverse events, we must be aware, although they are rare, you can get a mediastinitis, you can get some chest pain. And in fact, we can't have repeated Botox injections because you can then get fibrosis. So, so basically in practice, again, with Botox, it is described that it can also be a bridge to therapy, or in some instances, it can be palliative. What we can offer, which is more of a definitive therapy, and we do in our unit, is pneumatic dilatation. And this is essentially using a balloon to dilate and kind of stretch out that lower esophageal sphincter. So this is done in a graded fashion. You'll pick your diameter, it's usually 30 or 35 millimeters, and you'll do it in maybe 1 or 2 sittings, possibly even more. And the response has been seen, which is quite good. I will kind of mention that the response is not quite crude, so it's important to warn our patients. What we use, a lot of these studies, they judge response based on this Ikert scale, which is a composite scale of dysphagia, chest pain, and how severe it is. So there's a subjective element on that as well. So that's just needs to be borne when we look at the evidence, or at least the data for these modalities. So yes, back to the pneumatic dilatation. We do this under fluoroscopic guidance. Down again, we also do it down here in our unit. And importantly, the main side effect with pneumatic dilatation is the risk of perforation. And so as you can imagine, with your lower diameter, or your smaller diameter rather, balloons, the risk is a little bit less. I think it's in the order of less than 1%, but however, as you go higher, so the risk increases. So to mitigate that risk, we do it under fluoroscopy. However, sometimes it still does happen. And so it's important to have a surgical backup if you're going to offer the service. And the last modality I will talk about, which is probably the gold standard of management of patients with achalasia, is laparoscopic hair myotomy, or surgical myotomy. And this is where our surgical colleagues, through a lap scope, disrupt or cut the lower esophageal sphincter fibers. And then what they do at the same time, because one of the big side effects, or rather adverse effects related to this procedure, are reflux, they will do an anti-reflux procedure at the same time. So I'm sure some of you are aware of a Nissen's fundoplication. So that's when you take and you fold all the way around the whole circumference of the lower esophageal sphincter. That will obviously be counterproductive in this instant. So what you will do is either an anterior, which is a door fundoplication, or posterior, which is a toupee procedure at the time of myotomy. And this has the most durable success and most long-lasting success as well. However, all of these modalities, even though they have their varying levels of success, there's still a risk of recurrence. Encouragingly, however, if you have had a patient on pneumatic dilatation and they fail, you can then move on to a HeLa. And vice versa, if they've had a HeLa and that's failed, you can offer them dilatation. And just relate a little bit of evidence, the landmark trial for these modalities basically showed that there's no. I think my last slide, yeah, I was just saying that pneumatic dilatation and laparoscopic HeLa essentially are equally as efficacious for the management of these patients. And the last modality or treatment kind of modality that I would like to mention is a peroral endoscopic myotomy, or so-called PERM. And this is kind of a hybrid procedure or minimally invasive myotomy procedure, where we do this myotomy through the actual endoscope. And as you can see there in the picture, we make a hole, if I can put it that way, in the esophagus, and then we tunnel through the submucosal layer, ablating the circular muscular layer, and then clipping our defect to kind of then release the tension at the lower esophageal sphincter. And obviously, because this is a hybrid procedure, it mitigates some of the risks that you might have from a surgical point of view if you're going to do a laparoscopic HeLa, as well as the potential risk of perforation. It is also a slight risk, but not quite as high as pneumatic dilatation. And it is particularly useful, and I think I caught the last bit of what Dr. Seabi was saying to Dr. Matasela, is that it's particularly useful in a type 3 subtype of achalasia, where not only do you have this lower esophageal sphincter that won't relax, but you also have the spastic, or the spasm of the lower part of or the distal part of the esophageal body as well. And if you compare that to what was the gold standard PERM, the recent meta-analysis really shows that it is it is the best modality. However, it is quite technical, and obviously there is a learning curve. So hopefully we can offer this in the years to come. So then bringing it back to our patient, Mr. UM. He was offered a laparoscopic hair myotomy. I would have a video, but because of time, I think I'll just show you this picture. And essentially, they did what I described a few slides earlier on. And this was quite a successful procedure. I believe 2 years afterwards, follow-up, beginning of 2020, he was doing quite well from a dysphagia point of view. He had put on weight, and unfortunately, he subsequently got COVID, but at least he was stable from his other disease. So in summary, these manometric, or rather these motility disorders are rare. But certainly when you do have patients with esophageal symptoms, it's something worth considering. Of course, in practice, gastroscopy is our first mainstay. Obviously, we'll rule out obstructive process, but also we might find features in keeping with a motility disorder, or indeed maybe normal. And in this case, it might be, or not might be, it is indicated then to look at your motility disorders a little bit more carefully with a proper manometric study. And of course, depending on what you find, then you can tailor your approach appropriately. And yeah, these are my references. Thank you for listening. And yes, if there are any more questions or comments, yeah.